Professor Yoko Kato to give us the opening remarks, please, Prof.
So, everybody, hello. Thank you very much for joining the nurse session. I think a nurse is very important for all neurosurgeons, I think. So your dedication to this symposium and webinar is very, very important for all of us. So please enjoy, and also that we can obtain some knowledge and some skill, the neuroscience skill. Thank you very much.
Thank you, Prof. Today we have two speakers. The first one will be Professor Shoji Yokobori. He is the Director of Japanese for Acute Medicine and Director and Chair, Department of Emergency and Critical Care Medicine, Division of Neurosurgery Emergency, Nepal Medical School. And the second speaker will be Miss Annie. She's the Chief Nurse from National Brain Center, Jakarta, Indonesia. And our chairs for today, Professor K. Krista, and he will chair the first session. And Professor Krista is the Director and Group Head of Institute of Neuroscience and Spinal Disorder, MGM Healthcare, Chennai, India. And our second chair is Miss Elizabeth. She is PhD candidate in Nursing Faculty of Medical and Health Sciences, and she's attached to Frida Wakana Christian University, Jakarta, Indonesia. Our two commentators for today, Professor Irene and Professor Igan Shoshan. So now may I invite Prof. Krishna to introduce Professor Soji Yokobori. Please, Prof.
Thank you. Thank you very much for inviting me here to chair this very important and very nice session by Professor Soji Yokobori. Thanks, Professor Kato. Thanks, Matron, and thanks all my ACNN members. I had the pleasure of having many of you in Chennai, I think a couple of years ago, and I think this is a very important educational program. Professor Yokobori is going to speak to us about the response against severe traumatic brain injury, the experience of Level 1 Trauma Center in Japan, and he is highly qualified to do that because he was board certified in traumatology in Japan in April 2017. He's, like you just heard, the chair and professor at the Department of Emergency and Critical Care Medicine at the Nippon Medical School, Tokyo, Japan, since 2020, and he holds multiple positions and honors. In January 2021, he was the director of the Japan Association of Acute Medicine, and in March 2022, the director of the Japanese Neurotrauma Society. So I would now like to invite Professor Shoji Yokobori to deliver his talk. Professor.
Thank you, Dr. Chris, and thank you for your great, can you hear me?
Yeah.
Okay, great, yeah. Thank you so much for great this introduction. And my name is Shoji Yokobori from Nippon Medical School in Tokyo, and I really appreciate this great honor to be here with you all. And I also thanks Dr. Kato for this invitation. And thank you so much, everyone. And actually, today's my topic is about the traumatic brain injury. And in Japan, these days, elderly people is getting high, number of the people, of the elderly people is getting higher. I mean, the more, you know, in Japan, Japan has the highest longevity of the world, and this should be a new problem that we have now. So today's topic is about like this: how do we do for our next generation in Japan? And okay, and my presentation is about 30 minutes. So I start my video so you can hear that. So thank you so much. Okay, now we start. excuse me. Let me check. You hear this? Can you see this?
Yes.
Yes,
Okay, good.
perfectly.
Yes.
Thank you. I'll start this. Thank you. Okay, ladies and gentlemen, thank you for giving me this great opportunity to speak in this conference. My name is Shoji Kobori from Nippon Medical School. Today's my topic of talking is about the response against severe TBI, and which means our experience of level 1 trauma centers in Japan. And these are my disclosures and COIs in the United States and Japan. Trauma is a worldwide problem. As we see, every year, almost 6 million people are died by suffering the injury. And this number is larger than the infectious disease, like as HIV and malaria. And the number of the death by trauma is also higher than the COVID-19 in these 2 years. And trauma possesses the 8% of all cause of death in the world. And trauma is the main cause of death in younger population. And these days, SDGs, Sustainable Development Goals, are well focused these days. And one of the target of Goal 3 is relating to the trauma. So trauma is such a medical and social and economic problem. In Japan, we also had an experience of increase of trauma victims in 1970s. At the time, 17,000 people died yearly in 1970s. But these days we could reduce the number with helmet law and prohibit drinking and driving. We could have the number of the people who died, which was died by trauma, by 2,000 year. However, the other problem has been occurred. This is so-called preventable traumatism. This preventable traumatism is defined as the death even if the patient probability of survival is over 50%. And for example, when we miss like this intra-abdominal hemorrhage and like this cardiac tamponade, we may miss patient life. So therefore, the standardized patient care is so crucial in TBI management. And in Japan, the incidence of this preventable traumatism was almost 40%, over 40% of all trauma deaths. And to avoid this preventable traumatism, PTD we say, we Japanese neurotrauma surgeons had been making much effort for a long time. Herein, I show you a schema of our history, Japanese history against this preventable traumatism. First, we established an educational course for standardized trauma care in Japan. We say this JATEC, Japan Advanced Trauma Evaluation and Care. And within these 15 years, we also could establish JNTEC, an educational course for nurse, and JPTEC. This is an educational course for paramedics. And moreover, Japanese Neurotrauma Society also started the data bank project from 1998. And this also makes this clarify the TBI treatment and outcome in Japan. And we also established our own TBI TBI treatment guidelines. And now we published the 4th edition of this traumatic brain injury guideline in 2019. However, even in this our effort, we still could not reduce the number of preventable traumas in neurotrauma. I show this data from the Japan Neurotrauma Data Bank from the 1998 to 2015. And in this database, 32 level 1 trauma centers joined the data and collect the data of over 4,000 cases. And according to this databank project, polytrauma cases with at least 2 injuries categorized as AIS more than 3. So this means the polytrauma. And the incidence of preventable traumas was significantly reduced from 20% to 9%. But in a sole TBI, single TBI, there was no progress over this 15 years. And from this database, I can show you some more reasons of still higher incidence of preventable traumas. And we compare the features between the expected deaths and unexpected deaths. And the duration of transfer and the type of injury was not differed so much. But we can see the use of anticoagulant. It was a so strong factor to cause unexpected death. Also, in the group of unexpected death, the incidence of talk and deterioration had possessed a higher number of the cases. So when we are taking care of the TBI patient that use like this anticoagulant, we need to take caution, much caution, not to worsen the patient hemorrhage. And actually, Japan has the highest longevity of the world. And now there is so many elderly populations that are taking anticoagulant or antiplatelet. I show you the data from Japan Neurotrauma Data Bank. Almost 1/5 of the TBI patient, I mean the 18% of the patient took the anticoagulant or antiplatelet. And in like this patient, the incidence of talk and deterioration was significantly higher compared to the patient not taking the anticoagulant. So we can say reversal of the anticoagulant. Knowledge of the reversal of the anticoagulant is so crucial in our daily TBI care. And to avoid preventable traumas in traumatic brain injury, it is very important for us to have knowledge of the reverse drugs, like it is in a neurotrauma patient. And now, Japanese Neurotrauma Society started a Think First campaign for the enlightenment of the early consultation of the TBI patient that are taking the anticoagulant. And we also start the education to all younger neurosurgeons to know how to use reversal drugs for anticoagulant and for a TBI patient. And the pathophysiology of the coagulative disorder after suffering brain injury is also very important. I show you an easy schema of this unique pathophysiology in a TBI patient. And first, immediately after suffering brain injury, the serum concentration of the tissue factors increased. And this causes hypercoagulation first. Then, to reduce this effect, next hyperfibrinolysis is occurred with a peak of 3 hours after an injury. And to inhibit this hyperfibrinolysis, so next, the shutdown of the fibrinolysis was occurred in human body. So when we take the patient to the operating theater around 3 hours after suffering traumatic brain injury, so the controlling of this hyperfibrinolysis is so important, especially for initial TBI management. And I show you one example. This is a 15 years old male. And after drinking the alcohol, he was hit by the train at the platform. And after he's coming to our hospital, we took a head CT scan. And this showed a slight epidural hematoma in the right side of the brain, like this. And initial D-dimer was so high as over 40 microgram per ml. And this means he was already in the phase of hyperfibrinolysis. And this CT showed, this is actually the second CT scan that was took only 10 minutes after the first CT scanning. And as you see, like this large extravasation with severe midline shift was seen. And therefore, we had to rush for emergent operation. This is a movie at the time of the operation. You see we can see the terrible breathing without blood clotting. And to stop like this unique hyperfibrinolysis of TBI pathophysiology, this is very important to use tranexamic acid to control the like this situation of hyperfibrinolysis. And this is the final slide as a take-home message. Trauma is a worldwide problem. And we, Japanese neurotrauma surgeon, made much effort to improve the patient outcome. But still, we have seen a larger number of the preventable traumas. So the next, we should do a controlling coagulopathy, and we use reversal drugs of anticoagulation. And for this aim, now we are trained a young neurosurgeon, and we also mention to the importance of the reversal drugs of the anticoagulation in our new guidelines. And we also make a new campaign named as Think Fast. And we also want to mention about the enlighten of tranexamic acid use and more faster. We should be better to use this tranexamic acid to prevent preventable traumas.
And thank you so much for your kind attention. We hope we are the one. And please be safe, my dear all over the world friend.
All right.
Thank
That's
you
it.
very much.
Thank you so much.
Thank you very much.
Thank
That was
you.
a wonderful talk on standardization of trauma care, as well as the preventable neuro deaths, as well as very interesting the education of not only the doctors but also the nurses and the paramedics, which is, I think, very, very crucial, and that's a lesson to be learned all over the world. Over to the moderators now for their comments, please.
I'm sorry. Can you hear me?
Yes, I can hear you.
Okay, good. Yeah, thank you so much, Dr. Chris, and for this comment. And now in Japan, now we are trying to educate many teams. I mean, not only the doctor, but also the residency and nurses and paramedics also. I don't know in your country may have like this educational system about trauma care, but in United States or another countries have ATLS. So and this means resemble system with Japan, but yeah, now we follow the United systems of a United States educational system, but we hope we could make a original one to match the Japanese situation in these days. Thank you so much.
Yes, we too have the ATLS, but I think it is important that we make it, which is important and fits into our socio-economic system and works different parts of the country in a very unique way. And I think that is very important as well. So any other questions, please?
Yes, may I comment?
Thank you.
Can you hear me?
Yeah, thank you, Dr. Yaegawa.
Thanks. Congratulations for this comprehensive talk.
Thank you.
Education is very important, and we can identify 4 levels of education. Okay, the first level. The first level of education is the patient that consuming anticoagulant or antithrombotic. They should need to know the risk of minor head injury on the presence of coagulation, how to avoid, and what to do if even they have a minor. The second level of education, of course, is paramedic. In Israel, the ATLS-based system is very expensive and expansive here. So all paramedic went through the ATLS. The third level, of course, is the nursing, and the fourth level is the doctors. No doctor in Israel will get his license without passing the ATLS course. That's in this country. So education is extremely important. The other point which I would like to make is also, while we are educating, we should also tell about the risk factors. What will be the cases that the patient will talk and die? And one of the parameters, of course, you mentioned that anticoagulation is critical. It's critical up to a point that if a patient comes to emergency room with minor head injury, completely Glasgow coma 15, nothing, it's fine. We leave him for the nurses to continue follow-up. We do CT on admission, and routinely, even if everything is okay, we repeat the CT after 6 to 8 hours just because he was consuming aspirin, Plavix, or some other medication. And sometimes we see surprises in the second CT and the third CT, and sometimes they deteriorate. So it's very important to educate the nurses about that.
Yeah.
The other point is the mechanism of action or mechanism of trauma. There are high-risk mechanism and there are low-risk mechanism, okay? For instance, falling from height is a very severe mechanism. Hit by a car or by a train is significant only because of the mechanism. This patient will not discharge home for at least in our service for 24 hours. So just because of the mechanism, he fall for one floor, he was hit by a car, or those people that are working in the industry and working in the construction and the construction house building. At least in Israel, there are very high risk population patients. So if they come with this story, so we develop them special attention in terms of follow-up and in terms of repeating the CT. So these are very good points.
Okay, great. Yeah, thank you, Dr. Yaegawa, for your great comment. And I strongly agree that, especially in elderly people, and the so slight injury and just hit the head, and when elderly people drink having anticoagulant, like this slight head injury might cause the preventable deterioration easily within a short term, and yeah, also in Japan. And actually, the education for anticoagulant drug, I mean the reversal drug, is very crucial. And I also want to ask you if antiplatelet is very tough for reversal. I mean, we have no antiplatelet reversal drug for antiplatelet. So, and this should be a big problem in Japan. Almost all elderly people now having the antiplatelet drugs. So this is a great problem. So heavy problem in Japan. Yeah,
I agree. We have the same phenomena, antiplatelet, as opposed to anticoagulation, which usually you have an antidote and you can use it at the setup of the emergency room. With antiplatelet, it's more complex. You don't have antidote, and you need to follow them. And if something terrible happens, you have to give them just thrombocyte from the bank, from the blood bank, and go with them to the surgery if it is needed or required. So it's a big issue in Israel, up to a point that, you know, for prophylactic use of antithrombotic medication at the elderly age, there is less and less prescription now in Israel, because we realize that in the very old age, like above 70, there is no role of prophylaxis of aspirin Plavix compared to the age of 50. So there is now we can see a trend that it's less liberal to prescribe antithrombotic medication for the elderly patient. Anticoagulation is something else. Probably have their own indication for that. Cardiac problem, DVT, PE. But with the antithrombotic, we are pushing very hard here, at least in Israel, not to use them deliberately above the age of 70.
Okay, good. Thank you. Thank you for your comment, and thank you for your suggestion and knowledge to share with me. Thank you.
You're welcome.
Yes, Arian, any comment, any suggestion?
Good morning to those closer to Europe. It's wonderful to be together in the national usual. You can have at the same time colleagues sharing information from Japan with the growing aging population. Thank you very much, Sensei Yokobori, for sharing with us your data. It is challenging, and I admire how you put together the work. I will put together some words from Dr. Creation and some words from Shoshan from Israel. Population is aging. It's going to be impossible for us to avoid the use of antithrombotics. It is going to be present. We will need the use of those medications, but then the problem is, how are we going to avoid the presence of side effects in a patient with trauma in an older group, in an elderly group of patients? And I thank you very much for sharing your data. On the other hand, coming from a country like Albania originally, where such protocols are not widely applied, it's always it brings me back some bitter memories where challenges of taking care of patients with trauma come along with lacking investment infrastructure, and that's nothing to compare with the quality of life that is offered in Israel or in Japan. But then bringing that knowledge here in Canada, where I am, these protocols apply through all segments of care. It starts with the paramedics. And I must say, everything starts with the prevention, so much so that I should say it is constantly emphasized in the general practice in Canada the care of the elderly or those that are under treatment with anticoagulants or antithrombotics. So it starts with the family physician usually. That's how it goes. Advice on how to take care, how to avoid when possible trauma, which is not always the case. And then it goes from the paramedics and all the way to the level 1 trauma, which are different in so many in Canada. A combination of forces coming from physicians, nurses, and paramedics makes it possible for us to have the current success. In general, that is the case in North America. These are standard protocols that we apply, but whenever I have a chance to see data from Japan, I'm always surprised with the good quality of care that you offer to an elderly group of patients, and that serves for all of us throughout the world. We can gain a lot of information for our aging population. So thank you very much for you to share your work. And for Dr. Krish, thanks. And for Dr. Sridhar and Dr. Shashan to get together with their comments and introduction. Thank you very much.
Prof. Arian, thanks. Thank you very much. Prof. Sridhar, can you just do the closing remarks for the first session?
Sure. So, I mean, I think both the moderators, Professor Shashan and Professor Arian, have very clearly indicated how I think the education for neurotrauma must go forwards. And especially when we talk about the use of anticoagulants and antiplatelets, and there must be an education on how to pick up probably what we would think as a minor trauma, but would not actually end up being so. And I think that is a very, very important point. Admitting such high-risk patients for observation and keeping them under observation and perhaps repeating scans would be an excellent idea to follow. Of course, the standardized trauma care and education on neurotrauma for paramedics and nurses who look after these patients is paramount. And I think that is what we take away from this first session. Thank you so much, Professor Yokobori, and the moderators. It's been wonderful. Thank you very much.
Thank you, Professor Chris, and everyone. Thank you so much.
Thank you. Thank you. I understand Professor Sridhar will have to leave to another meeting, right, Prof?
Yeah.
Okay.
Thank you so much.
Thanks a lot for your time and thank you for your support. Professor Shoshan, are you leaving at 8 p.m. or?
Yes, I will be leaving in 25 minutes from now.
Okay, then we continue.
So I will stay with you for another 25 minutes.
Okay, thank you very much. Thanks for your time. Now, may I call one of my second chair to chair the session?
Okay. Yes. Thank you, Mrs. Yi. Okay. Hello everyone. Good morning, good afternoon, and good evening from Indonesia to all of you who are in Japan, India, Albania, Israel, of course, Indonesia, and other participants who are joining us from around the world. My name is Dame Elizabeth. I'm a nursing faculty in Krida Wacana Christian University, Indonesia. Now I'm pursuing PhD in nursing, neuroscience nursing, at the University of Auckland, New Zealand. It is a delight for me to join this fantastic webinar series, and it is an honor and privilege to be a session chair for the second speaker today. I believe that through this insightful event, we gather more knowledge and worldview of the current updates of the neurological care to improve our knowledge and critical thinking. So thank you so very much to Professor Yoko Kato, Ms. Yi, Ms. Christine, and all committee's members for the initiatives to make this event happen. I'm super excited to introduce our second guest speaker in this webinar series, Mrs. Emmy Modiasi. Now, please allow me share my screen. Okay, now everybody see my slide? Yeah. Okay.
Yeah, yes.
Yeah, thank you. I would like to name Mrs. Emmy Modiasi is the mother of Indonesian nurses who got all respect and pride from all neuroscience nurses in Indonesia. It is reflected in her 40 years career as a neuro nurse. She is now a senior advisor at Indonesia National Brain Center Hospital, Indonesia. Besides her excellent role model in neuroscience nursing, for me personally, she is an inspiring leader, wise and empowered woman, best mentor, and really good friend. But you may also Google her name and found that she already spoke in several national and international seminars and conferences. And she also authored some neurological nursing books and training modules. Her strong commitment to neurological nursing is proven to date, as she is now pursuing a doctorate in nursing in Erlangga University, Surabaya, Indonesia. Her research topics is consistent in stroke nursing care. She earned her bachelor's, master, and specialist in nursing from the University of Indonesia. Besides her educational degree, she had taken several training in stroke management, epilepsy, dysphagia in Singapore, Japan, Australia, Thailand, and many Europe and Asian countries. No wonder she has been entrusted as the president of Indonesian Neuroscience Nurses Association since 2012. So it's been a decade now. Please give a warmest virtual welcome to Mrs. Emmy Modiasi, who will share the topic of neuroscience nursing competencies in Indonesia. So, Ms. Emmy Modiasi, the time is yours.
Wow, thank you so much, Miss Dame Elizabeth, my best friend. Thank you so much. I think it's too high for me. Okay, good evening, Prof. Joko Kato, Dr. Cressida, and Prof. Susan, Miss Yi, and all participants. Good evening, I'm Annie from Indonesia. And this evening, I want to share about how to develop the neuro nursing competencies in Indonesia. May I share my screen? Is it okay? Good afternoon, everyone. I'm Emmy Modiasi from Indonesia. Firstly, I want to say welcome to the Honorable Professor Joko Kato from Japan as patron of ACNN, and Matron Yeti Cheng from Malaysia as president of ACNN, also all participants of this webinar. It's a great pleasure for me to join with the fourth of ACNN webinar today, and I want to share about how to develop the neuroscience competencies in Indonesia. May I share my screen? Currently, I am as clinical care manager at National Brain Center Hospital. This hospital is the top referral hospital on the neurological and neurosurgical patients in Indonesia, and it's located in the East Jakarta. It's about 10 minutes from the Halim Perdana Kusuma Airport. And also currently I'm a president of Indonesian Neuroscience Competencies Association. The outlines of our presentation today, firstly I want to introduction, and then about the NBC profile, and also I want to share the history of Indonesian Neuroscience Association, and mainly I want to share about the development of neuroscience competencies in Indonesia, and also about the INN's future challenges. Indonesia have 34 provinces, that our population is so big, about 278 million, and we have more than 1,000 hospitals, and part of them, about 35% funded by religious group and commercial enterprises. And at community, we have almost 1,000 primary healthcare services, and almost 80% of the poorest patient covered by national health insurance. Based on the research study from Ministry of Health, that the neurological cases, especially stroke, have significantly increased from 7 per mil at 2013 and significantly increased at about 11 per mil of stroke patients. On the other hand, on the nurse profile in Indonesia, we have about 20 professors in nursing and 187 doctoral or PhD, and for magister and specialists, we have more than 4,000 nurses. But most of them is from diploma, about 28,000 nurses. In Indonesia, for stroke ready hospital, we just center in Java and Sumatra, but in the other island like Sulawesi, Kalimantan, and Papua, we only have 1 or 2 hospitals. So we think that we need more hospital and surely more nurses that competent in the neuroscience nursing. Actually, the INNA is developed the same with the hospital. The National Brain Center Hospital have opening ceremony at 2014. We start with the emergency room with 12 bed capacities, and then 1 operating room, and ICU we have 3 beds at the time, and inpatient about 60 beds. But we have 1 CT scan, 1 MRI, and also 24 for laboratory. Top 10 diseases of the patient have come to the hospital is mostly stroke ischemic, and secondly stroke hemorrhage stroke, and thirdly is brain tumor. We developed the neurological care unit with 3 beds capacity, but right now we have 12 beds capacity. Actually, we have 3 kinds of intensive care, firstly is ICU, and then secondly we have high care unit, is special for neurological cases, and then thirdly we have stroke care unit. We have 11 beds capacity, and especially for stroke patients that have electrolyte imbalance, patient have arrhythmia, patient with seizure, subarachnoid hemorrhage, and also the patient got post thrombolytic. We have the first neurointensity and the ICU map of the operating room, we start at the only about 164 patients a year. Mostly we only have one operating room. And then at the 2018, we have 166 patients, and significantly increase at the 2019. We have 1,874 patients. It's for operated, but we have 209. At the pandemic period, at the 2020,
Annie, excuse me, Annie, not able to hear.
Since 2020, we have children special disability, and we have 56 patients a year. Surgery also became is an neurological procedure in which the patient is conscious during one of the procedure. The benefit of the craniectomy maximize the tumor section, and secondly, we have the neurologic function of the brain syndrome, intraoperative and also minimize visit, article, and also decrease the average stay at hospital, and also the most disability is patient with sugar and in their vision. So when we see all the intensive care that much share
Oh, yeah.
Stroke team to Royal Hospital at 1995, and then after that we back to Indonesia, and we we start to operational of stroke unit, the first stroke unit in Indonesia at 1995. Actually, at the time, we start to develop the neuroscience nursing competencies, like how to monitor the level of consciousness of the patient, how to assess the motoric function, and etc. And then also we conducted the nursing course about the management of stroke patient for all nurses in Indonesia. And then after that, we are lucky that we invited by Matron Yi from Kuala Lumpur Hospital to join with the Neurotrauma Conference at 2011. And then the next year, we also invited by ACNN to join with the Asian Neurosurgical Nursing Congress in Istanbul. And after that, we with other nurses from Faculty of Nursing and from other hospital, we found the INENA, Indonesian Neuroscience Association, by pre-congress and congress. And the inauguration of the president of INENA for period 2014 until 2019, and then for the second period, the inauguration at about September 2019. Actually, in Indonesia, we have other nurses association, and HIPNI, I think, is number 17, so it's the younger than the other. And currently, we have 5 branches in Yogyakarta, Central Java, and East Java, East Kalimantan, and South Sulawesi. And thank you so much to Miss Yi that she always supported us to develop the neuroscience nursing in Indonesia. What the neuroscience nurses? The neuroscience nurses are the nurses who take care of individuals who have experienced change in function or alteration in consciousness and cognition, communication, mobility, rest and sleep, sensation, and sexuality. A nurse working in the neuroscience field should enjoy technology and working with people and have both physical and psychological stamina. Actually, the frame time is very broad of the neuroscience practices, from the phase hyperacute and then acute phase, subacute phase, and until the rehabilitation phase. So we have developed the neuroscience competencies from the nurses at the emergency room, and then at the operating room, and the intensive room, and also the neurological or neurosurgical ward. Because we have both responsibility as the nurses at the hospital and also as the member of nurses association. There are this slightly different job, like at hospital we have designed the neurological nursing form. We have to develop the guidelines and nursing procedure standard, also the clinical pathway, and give orientation program for the nurses and also for nursing students. And also we have to examine the nurses competencies, and then we have also conducting the credentialing for nurses, and also we have to conducting the courses or training and education. And another side, we have also responsibility as member of Nursing Neurosciences Association, like we have to do the annual scientific meeting, we have to develop the neurosensing competencies, also we have to design the module and curriculum, and also we have to conducting the neurosensing courses, seminar and workshop, and also we have to campaign and public awareness about the neurology cases like stroke, also the multiple sclerosis, Parkinson's disease, and the brain tumor. And also we have to organize some disease training. Yeah, we have to evaluate self-evaluation for ourselves. Are we competent in the neuroscience nursing area? And what area we competent in? What performances are we competent on? And how do we know that we are already competent? And I think the competency need to be standardized. There is what the difference between the competency, core competencies, competency. I want to share about this. The competency is the necessary knowledge, skill, and attitudes a nurse must possess in order to perform a set of defined activities to an expected standard. And the core competencies is a standard set of performance domain and their corresponding behavior standard which a nurse is required to demonstrate it. The competence is the ability of a nurse to demonstrate the knowledge, skill, judgment, and attitudes required to perform activities within the defined scope of practice at an acceptable level of proficiency. And competent is being able to demonstrate the necessary ability, knowledge, skill, and attitude across the domains of competencies at standard that is determined to be appropriate for that level at which a nurse is being assessed. In Indonesia, we have 5 domains of the ASEAN Nursing common for core competencies. That firstly is practices based on ethical, legal, and culturally sensitive. Secondly, we have had the professional nursing practice, and we also the nursing competencies is involve the education and research, leadership and management, and also personal and professional quality management. Firstly, the practices based on the ethical, legal, and culturally sensitive. So we have to demonstrate and maintain ethical nursing practice. Secondly, we have to demonstrate understanding, knowledge, accountability, and responsibility of the legal obligation for nursing practice. And also we have to provide culturally appropriate care. The competency indicator are comply with the Indonesia Nursing Code of Ethics, and also we have to practice in accordance with institutional and national legislation, policies, and procedural guidelines. We have to maintain clear and legible documentation and records, and also we have to ensure on physical, cognitive, psychological, and emotional fitness to practice and deliver safe care. Secondly, that the nursing competencies have include the professional nursing practice. Like we have to demonstrate effective communication. We have to ensure consistent and continuous holistic quality of care. We have to maintain safe environment through the use of quality assurance and risk management strategies. And also we have to apply strategies to promote health and prevent illness. Thirdly, we have to inform the leadership and management system. We have to demonstrate effective management and leadership skill in the profession of quality nursing care. Secondly, we have to use principle of quality improvement and incorporate them into nursing practice. And also we have to provide a safe working environment.
And finally, we have also to use the professional development. We have to demonstrate accountability for one's development and status as a professional registered nurse. We have to demonstrate ability to apply knowledge and skill in research in different healthcare settings. Now, we discuss about the neurosensing competencies. Skills in patient and family education, especially regarding the neurological condition. We have to have skill in using the nursing process from assessment until evaluation to plan and implement care. We also have to have knowledge of neurosensing, including anatomy and psycho and physiology, illness manifestation, and also the medical treatments. We have to have ability to manage families and individuals who are grieving loss, and also actually we have to
Miss Emmy, would you please unmute your mic? Thank you.
nurses have to comply with the Indonesian Code of Ethics. This is the basic beginner, and then we have to have effective communication. We also have competency for monitor vital sign, the competencies of how to prevent and how to control the infection at the hospital, how to conduct patient safety, how to conduct the personal hygiene, and also the nurses from the beginner have to competence also of the how to provide the nutrition, how to provide the fluid and electrolyte, how to maintain the patient have fluid and electrolyte balance, and also how to have the patient in the elimination, such as mixing and purification, and also how to help the patient to mobile on bed. The effective communication not only between staff, but also the nurses have to competent in the effective communication with patient and family, of also communicate to other head alike. The level 2 is basic. So the nurses have competencies of assess the neurological status, such as GCS, pupil, and motoric function. And nurses have competency for apply collar neck, perform local technique, and also conduct the dysphagia screening, conduct the swallowing test, conduct the scanning bladder, and also competent to do bladder training. Also competent to apply elastic stocking and also apply of the DVT pump. In the third level, we call it intermediate nurses. So the competencies are assess cranial nervous 1 until 12, and then assess the meningeal sign and assess the reflexes. Also perform on the National Institute of Health Stroke Skill to evaluate the severity of stroke patient, and then conduct the plasma exchange, conduct the IV thrombolytic therapy, and also the competence of taking care of patient with EVD, pre and post craniotomy, and also pre and post angiography. The level 4 of neurosensing is we call intermediate. The nurses have competencies as a leader of journal reading, case report or mortality report, and so conduct nursing audit and supervise of nursing quality to the ward, to the operating room, to the emergency room, and also as a leader of nursing research, and also the competencies of conduct of publication of the result of the research. The 5 level of neuroscience nurses is the advanced nurses. The competencies are as clinical care manager, office manager, and conduct the nursing innovation based on the evidence-based practice, and as leader and review and revise the standard of clinical nursing procedure, also as an author of neurology guidelines book for nurses. I want to share about the nursing assessment. In my hospital, all new patients have to assess of the allergy, and then duration the patient come to the hospital, and then the health history and medicine history, and then physical examination, psychosocial, or risk, functional status. Usually we use the Bartel index, and then we have to assess the pain. We have to conduct dysphagia screening and nutrition screening. Also, we have to assess the education need of the patient, and also we have to conduct the discharge planning. And the neurologic assessment, we have to assess the GCS, we have to assess the vital sign, the pupil, the functional motoric, the visit neurologic of the patient, and also the psychological and emotion of the patient. In the neuroscience area, actually we have more than 10 nursing diagnosis, and we have to define the nursing diagnosis after we assess the patient. These are the example of nursing competencies at the emergency room. So we have to conduct the tracer, and then we have to maintain the airway breathing and circulation on the stable status, and we have to monitor the vital sign, we have to monitor neurological status. The nurses have to competence to do the lock roll, to apply the cervical collar, to conduct the National Institute of Health Stroke Scale, and also the nurses become to stroke responder or stroke activator, and then to conduct the IV thrombolytic, conduct the screening, dysphagia screening, also measure the post-voiding residual patient at emergency room. These are the neuroscience nursing competencies at ICU or neurology critical care unit. So the competencies are intubation or preparation of intubation, and then weaning process, setting the mechanical ventilator, to do the chest physiotherapy, to do the range of motion, how to position the patient, how to ambulate patient on bed, to take care patient with EVD, to take care the patient of lumbar drain care, to take care the patient with patient care, also the craniotomy wound care, how to apply the elastic stocking on the TVT pump. These are the neurosensing competencies at a stroke care unit and high care unit. The nurses have to competent to maintain the airway breathing circulation, and then also to do the chest physiotherapy, to do the range of motion, how to position the patient, how to ambulate the patient on bed, and also to take care of the patient with EVD, VPShan, or lumbar drain care, also to take care of the patient with post-craniotomy, how to take care of the patient with NGT and PEG, and how to apply elastic stocking and DVT pump. The nursing care of post-thrombolytic essential for nurses from the stroke care unit. And also the nurses have to competence to think of eating and tapping. Also nurses to take care of the patient and the end of life stage or terminal ill. And also the nurses have to competent to educate the patient and family. This is the new one, the intensive care special for post-anesthetic care unit. Then the competencies are monitor vital sign and neurological status, will also maintain the airway clearance and oxygenation, monitor ICP, to take care of the patient with fever, and to take care of the patient with an electrolyte imbalance, and also how to take care of the patient with nausea, vomiting, how to control seizure, and also to conduct the work and in neurology and neurosurgical ward. This point is nursing care of stroke patient and other neurological cases. We have to monitor vital sign as regular and then monitor the neurological status. The important thing is the nurses have to competent of to do early mobilization, swelling management, bladder training, and also discharge training. So that's why we, as regular, we invite the physiotherapy to teach nurses how to positioning the patient, how to ambulate, and how to transfer the patient from bed to the chair. As manager, we have to control the competency of our nurses. So we have to audit, we have to supervise, and also we have to develop their career by training and courses. And also we have to develop their career. So every year we conduct the nursing course for nurses from ICU, from stroke care unit, and also from the ward. And also we conducting the basic neuro lab support course for nursing student and for nurses all part of Indonesia. Like this picture, this from Ainina lecturer. She educated the nurses from South Sulawesi about the nursing care of stroke patient. And also we conduct the neurocritical care workshop. And the Ainina also involved in some neurology organization event such as Indonesia Multiple Sclerosis Group and also Indonesian Stroke Club. Like this, the Multiple Sclerosis Day every year, we involve to campaign for public about the multiple sclerosis disease and also about the stroke disease. And also we have collaboration with International Conference of Congress. This at the Kuala Lumpur conference, and this one at the Thailand. And also we collaborate with Vietnam in September 2018, how to take care of the stroke patient and the post-craniotomy patients. And last, we have shared about, we have challenges, for in challenges like the how to, we have to expand the membership to all Indonesia region. We have to developing neurosensing competencies because yet we also have developed in the stroke competencies in neurological competencies in hospital. But I think we have also developing the neurosensing competencies for community or family nursing at community. And also we had to developing the neurosensing courses developing a graduate certificate of neurosensing program. So we have idea that we collaborate with National Research Hospital and maybe another country to develop the graduate certificate of neurosensing program. And the last, we have to developing also research and neuroscience setting. This is we have to collaborate with other country also. Thank you for your attention. And if you have question, please, I am glad to share with all of you. Thank you.
Thank you so very much for your comprehensive explanation about the growth and development of this association. So from your explanation, in less than 10 years, from 2014, Indonesia has set the standards of neuroscience nursing competencies into 5 levels. So now I'm going to give an opportunity to our distinguished commentator and participants to comment or ask questions regarding our current topic. I saw Professor Arian from Albania still with us here. Perhaps
yes, I will.
Yes.
Yeah, I will definitely like to join. I will start with you first, Elizabeth Tarihoran. Please allow me to congratulate you on your next step of education and moving to New Zealand for graduate studies. It's awesome and outstanding. Good luck with that education, and I hope you will have the opportunity to take that knowledge back home with what you are doing, and then I'll take over to Emmy Modiasi. What she has been doing in Indonesia, we find pride in this world. Neurosurgery is a team work. It is irrelevant where you are. You need a group of professionals to work with. And I see that constantly being the case from all the way to the other side of the East Hemisphere, well, here where we are in North America. Thank you very much, Ms. Emmy Modiasi, for your presentation. I must say, I owe this moment of professional gratitude to Professor Kato and to my dear friend Matron Yi Chang for being here with you today. I've learned a lot. Sharing your experience, how things have developed, how you have been instrumental in helping colleagues grow professionally in Indonesia, interfere with changes which are positive changes in development in medicine in general and in neurosciences, specifically Indonesia. It is outstanding. And it goes to tell, and this is my closing remark, that with striving and perseverance, success can be achieved. And both of you showed that us today. Thank you so very much. And I wish you further success in all your endeavors, professionally, wherever you take your life, either it being in Indonesia or in New Zealand.
Thank you so very much, Professor Arian. This is such a strong motivation to all of us Indonesian neuronurses. Thank you so very much. Okay, I saw one participant with the name similar with Ibu Emmy Modiasi, raise her hand. Do you have any question to Ibu Emmy Modiasi? Yes, please. Would you please open your mic, Ibu Emmy? Yes, thank you.
No, thank you, Miss. I have any question yet? I haven't any question yet.
Oh, okay.
Sorry.
It's okay. Okay. Anyone here have a question or comments or sharing? We would like to hear.
Ada pertanyaan enggak?
Okay. Or Professor Arian, would you please share to us, maybe you have any experience from a nursing perspective in Albania nurse. we would like to know the updates from Albania as well. Maybe you.
I'll be very happy to share some historical moments, but in honest truth, the state of neurosciences in Albania is not at what you have been presenting. It is not because of the lack of will from the students that graduate nursing school. And most likely it comes because there is lack of infrastructure and support from the administration to have them grow professionally. In my case, I used to work back home, both at the only department of neurosurgery at the capital city of Tirana in Albania. And then before moving to North America, I worked for about a year at the only level 1 trauma center in Albania. Professional growth comes with your work. It is not necessarily part of a special education.
Okay.
I think in the very near future, things are going to change. The need for specialized practitioner in each subspecialty or field is a must. And I'm not saying this only in neurosciences, that's going to be the case in general surgery, in the care of transplant patients, in the care of patients with chronic lung diseases. It requires a vast length of knowledge before you start taking care for this specific group of patients who require long-term care and support. And if we were to bring back the earlier talk from our colleague in Japan in regard with trauma, that goes to say that some of our patients need follow-up for weeks or months. And only in a specialized center you would be able to have that care. In the case with our nurses, I must be honest, when I started residency, I was blessed to have been part of a wonderful team. It was a group of great humans, not necessarily fully trained and specialized in everything they were doing, but they had the willingness to learn whenever the opportunity would arise. What I mean by whenever the opportunity would arise, it is that we were not able at that time to offer them support financially and institutionally for them to train abroad or travel and visit other places. I have hope that with the new chair coming, the departmental chair is underway for a new chair to come in Albania, and I hope with the new colleague that's going to take over this will change. It is not in the stages that you have been presenting institutionally, but when it comes to the heart and the minds of nurses that work with us and we working with them, I must say it is in one of the highest standards I've ever been working with. And thanks for asking me that question. You brought me back some great memories.
Thank you so very much, Prof. Arian, for sharing your experience. It seems you really care and concern with us as a nurse professional. So it's a very insightful message for us and remind us that the first thing we have to have is a willingness. So thank you for this very good reminder for us. Okay.
But let me tell you one last thing.
Okay.
I'm not sure that there are cultural differences, and I'm not able to make a comparison on that. But when it comes to the experience I've had in Albania, in general, I'm not saying 100% of the cases. In general, most of the colleagues, I mean physicians, do highly respect the work of our nurses.
Mm.
And that is, and it is one of the keys to success. It doesn't matter how highly professionalized you are in your field. If you are not respected, or if you are not given roles to take part in the care of your patients and our patients, it's not yours, it's not mine, it's our patients, then you are never going to be able to find yourself in a place that you will enjoy working. I see that in the opposite in most of the clinics in North America, where nurses, paramedic, physician assistants, physicians are all part of an assembly. And that assembly is a machine that works from all these parts combining their work together. And the work ethic and the culture is such that it is irrelevant of your title. Relevance comes with your knowledge and you being part of a team. So if you are a nurse and your job is such that you take care of a patient, it doesn't matter in which sector in neurosurgery, that is what you are respected for. If you are a physician, your care is respected for what you do toward the final goal. And the final goal is the success to giving the best outcome of the medical treatment to your patient. And that requires a team. It requires a team. You showed me that you have a teamwork in Indonesia, and that's wonderful. Thank you so much for sharing that with us.
Thank you so much, Professor Arian. You share from many countries experiences. So we are so grateful to have you here, Professor Arian. We got a lot of information. Yeah. Maybe Ibu Annie want to comment or sharing something regarding what Professor Arian shared.
Yes, I think I agree with Prof. Arian. Thank you so much for your information, for your support to us. Actually, the nurses is part of the team, so we have to truly willingness to take care of the patient of our best thing. Okay, thank you.
Okay, thank you, Miss Emmy Modiasi. Okay, I think we are going to move to next section. Maybe I can hand in to Mrs. Yi for the next session.
Thank you, Miss Annie. Thank you, Miss Elizabeth, and Prof. Arian is always there to support nurses. And thank you for your time, Prof. Arian. I know you're very busy. In spite of your tight schedule, you are still with us. Thank you very much. I do agree, yes. Nurses, surgeons, doctors, all must work together as a team, and the responsibility, the accountability must be there to be a good nurse. So once again, thank you very much, Prof. Arian, for always there to support us. And of course, Prof. Kato also will be always there. If I have anything, the first one, I will refer to Prof. Kato. Thank you very much, Prof. And I think we have come to the end of the webinar. Shall I call upon Professor Yoko Kato to give us the closing remarks, please, Prof?
Yeah, thank you very much for the two lectures. Were wonderful, I think. And Dr. Arian used to be with us, one of the best fellow from Albania at the time. And now he's working on the glioma, and he's excellent. He became an excellent neurosurgeon, especially in Toronto. And also he is very concerned about how to promote the nurse improvement, especially the nurse practitioner or physician assistant. So I think I was so impressed the Anna presentation, because Indonesia promoted this so highly level right now, I think. So that you're very lucky. So in the future, I think you should have more communicate internationally, such as America or North America, and also the Europe. So you can have a more extend your community and have more, I think, exchange your knowledge and opinions. It was a wonderful webinar tonight. Thank you very much. Arian, thank you so much.
Thank you, Prof. Kato.
Thank you, Professor Yoko Kato. Okay, we have come to the end of our webinar. The next will be on the 20th of August, and we will have Prof. Andy and Dr. Arian. These two speakers give us a very wonderful talk. They will be talking, Prof. Andy will be talking on about equipment of neurovascular operations. And Dr. Andrew will be talking about pediatric epilepsy, initial management and surgical consideration. And Dr. Andrew is a nurse practitioner. I hope we will have more participation from the nurses. Once again, thank you, Prof. Aaron. Thank you, Professor Yoko Kato, for all your support. Dr. Liu, for always there. I also I always refer to him if I have any doubt. Thanks again, Dr. Liu, for always there to support me. Thank you very much, everybody. Hope to see you again. Bye.
Bye-bye.
Bye-bye.
Thank you very much. Wonderful.
Thank you.
Wonderful.
Bye.